This is a case of baby of Vijay Lakshmi, early term 38 weeker.
No, the slides are not visible. You have to go to full screen. Yeah, now it's okay. Carry on.
It's not changing. Yeah. Sorry for disturbance. Actually, this one is a case history of baby of Vijay Lakshmi, early term 38 weeker, SGIUGR baby with a MSL and severe parental asphyxia. Baby delivered by spontaneous non-vaginal delivery. Born with a 32 years old G2P2 and L2 mother with non-consensual marriage and spontaneous conception. Baby didn't guide and incubated at birth. In antenatal history, antenatal scans features are of suggestive of IUGR. And in natal history, baby born with a normal vaginal delivery didn't guide at birth. Apgar was below 3 to 4 and so intubated at birth. Baby birth weight was minus 1.8 standard deviation, length is minus 0.48 standard deviation, and head circumference is minus 21 standard deviation. That is suggestive of asymmetric IUGR. In the postnatal event, baby intubated at birth and admitted in level 3. On general examination at admission, the tone volumes and sensorium was comatose. So the criteria of therapeutic hypothermia is Apgar less than 5 at 5 minutes, resuscitation intubation at birth, ABG is pH less than 7, base deficit more than minus 10 millimole, then moderate signs of moderate encephalopathy like lethargy, hypotonia, and spontaneous activity, and multi-organ dysfunctions. In this case, CNS and pulmonary meconium aspirations are involved. At the time of admission, day 1 to 5 of life, in the view of moderate encephalopathy, therapeutic hypothermia started at 2 hours of life, baby extubated at CPAP and then to room map at 38 hours of life, and remorbing started in between 72 hours and later coding stopped. But at day 5 of life, baby having one episode of multifocal chronic type of seizure, so we loaded with phenobarbital and later maintenance dose of started. On investigation, at the time of admission, hemoglobin was 12.6 and TLC counts are increased around 23,800. So that all parameters are within normal. On day 14 of life, phenobarbital tapered and MRI brain was done. On day 16, MRI report shows dural sinus thrombosis involving the one-third of the sagittal and transverse sinuses. This is the MRI venogram deficit. In between this, this is the sagittal sinus, which is a deficit on this, and this is a transverse sinus. In venogram, this one is a obstruction is there, and this one is a flare MRI, which suggested was superior sagittal sinus hyperintensity is there, which is also suggestive of thrombosis. So, behalf of this, we started unfractionated heparin, and after that, low molecular weight heparin. Low molecular weight heparin started on day 23 of life, continued for 6 days, and then planned for discharge. And we planned for revert MRI after 6 weeks of scans. This is a baby picture of baby before discharge. After 6 weeks of therapy, baby is growing well. Baby weight is plus 1.5 standard deviation, length is plus 3.26 standard deviation, head circumference is plus 1.6 standard deviation, and this is a growing baby. This heavy door is no head lacking is there, and we report the MRI report shows 6 pieces of treatment showing in T1 weighted image hypointensity in superior sagittal sinus, which is a void. That is a normal phenomenon. In a flare image, this void is also there. So now come to our discussion. Mostly CSVT incidence range from 0.6 to 12 per lakhs live births. mostly CSVT overlooked because of unawareness of the clinical practitioners and relative difficulty of radiological diagnosis. In most cases, around 66% of cases, medical attention come under 48 hours of life in the form of seizure. Then come to a neuropathological part. Mostly thrombosis involved the superior sagittal sinus in 65% of patients. Then later to the 50% lateral sinuses, and even hemorrhagic infarction with 40 to 80%. IVH is also there, 35 or 55%. The principal finding is brain edema if the patient is without infarction. Then risk factors are two types, maternal and peripartum complications. Maternal is preeclampsia, gestation diabetes, maternal fever, pseudoamnionitis, and the peripartum complications are meconium, hypoxia, dehydration, and sepsis. Then clinical features are most common seizures, 60 to 70%, then less car lethargy, poor feeding, apnea, or inability. So diagnosis, initial evaluation, most clinical finding is seizure. So we have to rule out other forms of seizure, other causes of seizure like metabolic and electrolyte disbalances. And second is neuroimaging. There is a key role for visualization of thrombus and secondary changes like hemorrhagic infarctions. Then cranial ultrasound is a screening tool to detect any IVH or infarctions, whether it is in thalamic region or in central hemorrhagic infarctions. Then comes to the definitive diagnostic on neuroimaging, which is MRI and venography. It definitive diagnostic in the terms of detection of infarction, which is coupled with the time of flight. Time of flight is a blood flow between the high magnetized zone to the low magnetized zone, from which the hyperintensity of blood flow will be detected. In this, cerebral venous sinuses and deep venous thrombosis is imagined without contrast. This is a MRI scan. This is a first A scan is there. This is a hemorrhagic area, which is a periventricular area, and this is the second one is a thrombus in this particular area. This one, both one is in the T1 images. Then this third one is a venogram. This part is showing this sagittal sinus thrombosis, and this lateral sinus is also involved. And this one is a third one is a intracerebral veins. So this one is also suggestive of thrombosis. This one is a T2 image which showing a punctured hemorrhage, and this is also a venogram which showing the decreased transverse volume. So prognosis, mortality are very 10 to 20%, and long-term neurological complications like motor involvement is 50%, rest other are cognitive seizures involved. So in management part becomes to management, anticoagulation therapy, most commonly low molecular heparin with close monitoring. Follow-up images include after 6 weeks of treatment. If no reconnaissance is complete, then additional 6 weeks we have to carry out. There are some uncertainties between treatment. According to ACORD, this American Heart Association and American College of Chest Physicians are differ. For neonates in American Heart Association, considered AC therapy with the unfractionated heparin or molecular heparin in the prothrombotic disorders. And according to American College of Physicians, we have to decide on the basis of intracranial hemorrhage. If intracranial hemorrhage is present, then we have to do a 5 to 7 days of scanning. After that, if clot is progression, then we have to start treatment. If it is not present, then we can start at the time of for 3 to 6 months at the time of diagnosis. Thank you.
Yeah, I think Mohit should be very clear with what are the take-home points and what is that you are trying to say. When do you suspect thrombosis?
Sir, actually, at the time of
in your case, it came as a surprise finding, or you voluntarily looked for it because you are not able to explain any finding in your case.
Sir, actually, at the day 5 of life, we suspected seizure was present. Okay. So suspected day 5 of life, some abnormality is there. So we planned for MRI. Then we land up to this one.
So what are the sinuses involved in your case?
Sir, superior sagittal and transverse sinus.
Okay, so what does it indicate?
It indicates, sir, there is a thrombosis there, sir, actually. Complication of uh, peripartum asphyxia.
Why do you think your case went in for a thrombosis? What you should have done to prevent it, or what could have been done?
Proper prothrombotic workup.
There are two things I think you skipped that in your presentation actually. This baby is a third born baby actually, and previous two babies are there, out of which one baby is having a developmental delay. That baby is also having a similar presentation of seizures during the first week of life actually. That is a very important history basically in this child. So
Yes,
what is the relation with that? Previous baby is having a development delay, and that baby also had a seizure, not during the first initial time, but in the fourth day or fifth day of life. So what does that suggest?
Some metabolic causes are inborn of
Fine, right? I think. Can you stop your screen? I'll just show one of the few things actually.
Yes.
Now, are you able to see my screen?
Yes, sir.
It is in full screen, right? This is one thing which
Yes,
I prepared a while ago actually, and no, actually, these are things I just wanted to highlight. Actually, this is a relatively new disease. Previously, people are not diagnosing that, and now because of the many studies where they do MRA routinely for birth asphyxia cases, they try to find out what is the incidence of these thrombosis. And it was surprising that this is the international study on cerebral vein and dural sinus thrombosis. They found that the transverse sinus is 86% involved, and superior sagittal sinus is 62%. These two are the most common sinuses involved. So neonates are at risk of developing thrombosis. Why is that so? What do you think is that due to? Why are neonates at risk of developing thrombosis? What do you think is the reason for that? Okay, the lifetime risk of having a venous sinus thrombosis is the highest in newborn. So before going to that, I should like to have the brief anatomy. As you can see here, this is the superior sagittal sinus, and this is the inferior sagittal sinus. So these two are the major superficial sinuses, and this is the what do you call this transverse sinus. So these are the two transverse sinuses, and this is a straight sinus, and this is the cavernous sinus. Ultimately, everything drains into the internal jugular vein. Most important thing is that there are many anastomotic connections. So there are many anastomotic connections which interlink all these things, and the degree to which these anastomoses are present will determine how significant or how symptomatic the patient is going to be actually. So one other thing is that these are present in the subarachnoid space directly above it is by periosteum and below it is by dura. They literally have no muscular tissue. So that is a significant problem in newborns. And also they possess no valves. And most of the time your baby
వేరే చోటికి తీసుకెళ్తాం ఇంటికి తీసుకెళ్తే ఈరోజు పాలు అవన్నీ తాపిస్తే అది ఇంకా లోపలికి పోయి ఏమైనా ఇబ్బంది అయ్యే అవకాశం ఉంటుంది. రిస్క్ చేయడం ఎందుకు? అట్లీస్ట్ 24 hours to 48 hours హాస్పిటల్లో.
Please mute.
Yeah, sorry, I had to mute one person. Fine, okay. Yeah. And there are certain features which differentiate these things from adult or a pediatric population. So that is one thing, and no valves predisposed to them, and no muscular tissue predisposes to that. And another most important thing is that they are often lying supine. So that supine causes stasis to some extent, and that causes some problems. And there are a few other what you call as a thumb rule when you are dealing with the sinuses, cerebral venous sinuses. Variation in the superficial venous system is a rule. As you can see, there are two things which form the superficial. There's the superior sagittal sinus and the transverse sinus. So all other things are deep inside. So these are not used as the anatomical landmarks. Whenever you take into consideration for some other landmarks, we often take into consideration only the deep venous system because that is relatively not variable as the superficial system. And vein of Galen obstruction, usually it leads to instant death because it covers the vital areas. It effectively obstructs deep venous flow. Other than that, most of the time you will be dealing with superficial cerebral venous system. That is the most common thing affected. So no, this is a virtual triad of thrombogenesis. You need a hypercoagulable state, you need some stasis, and you need some vessel wall damage. So what is this hypercoagulable state? So hypercoagulable state is that these neonates have a tendency to have some amount of hypercoagulability. Both the prothrombotic as well as the antithrombotic tendency is very low in newborns. So that is compensated to some extent by the rheological modification. So whenever you have some stasis, which is typically manifested by something like dehydration, polycythemia, so all these will cause some amount of stasis. So that will cause some problems basically. And another thing is the vessel wall damage, which initiates the thrombotic stimulus actually. So these are the essential triad actually. So the risk factors again, as Mohit has already told, preeclampsia actually reduces the atrioplacental flows. There is some amount of stasis which leads to hypercoagulable state. And diabetes also has some vascular injury which leads to infarction and any type of placental disorder for that matter. And sepsis is a comorbid condition. Here we had some probable sepsis, we are thinking of that. And another important thing is that there is some reported evidence of association with hypothermia. So even one study indicates that it is present in 10 among 37 babies, so which is very huge actually. So, but the convincing evidence comes from the Toby trial where they have put 121 babies, among which the MRI is done for all. MRI with venogram is done for all, and they have found only 3 cases, of which only 1 in the trial group and 2 in the control group. So that is a bit reassuring that hypothermia may not be linked with your venous thrombosis. So this is one thing which is very, very important to take home from this presentation actually. There are 2 different phenotypes. So one is even we can differentiate into early onset varieties and late onset varieties for this pathogenesis. So the most common thing is that it is because of a traumatic delivery, vaginal delivery, either instrumental or even a difficult delivery itself per se. So due to the molding, extreme molding, it can directly affect the venous sinus flow, and that can also injure the venous endothelium. So this will present very early in course of disease. And another is the late presentation where your dehydration gets predominant, is the predominant finding actually. So here we had a difficult delivery, but we put therapeutic hypothermia also, which is supposedly or doubtfully a risk factor. And there is some amount of preeclampsia also, and the previous baby is affected also. So, yeah, but we didn't have an early presentation. That is atypical in this one thing, which is atypical in our case. So there is no evidence of dehydration. Urea creatinine is also normal. Baby's weight is also good otherwise. And baby had a seizure, which is otherwise unexplained. So we actually had to get the approval and COVID negative report before doing MRI, and we could do that only by 14th day. And there are some. So this presentation is what is very typical here actually. So the mechanism of injury here, there are 2 different types actually. So one is the occlusion of veins and another is the occlusion of sinuses directly. Occlusion of veins causes congestion and increased pressure, which leads to cytotoxic as well as vasogenic edema. So this can be easily identified by your diffusion weighted imaging in MRI, this cytotoxic edema. So this venous sinuses, it typically manifests as a raised intracranial pressure. So that is more in an older child rather than in your case actually. And another thing is that there is a strong association with intraventricular hemorrhage. Typically, term neonates present with unilateral thalamic hemorrhage and periventricular white matter lesions, and preterm neonates also have a late onset IVH. So, in fact, it is said that whenever there is a late onset IVH, you should always rule out a cerebral venous sinus thrombosis. So, mind you that this hemorrhage doesn't contraindicate your anticoagulation therapy or thrombolytic therapy. So, we have to start heparin despite the presence of hemorrhage. In fact, the hemorrhage can be present at multiple sites, because all these, when the vein is thrombosed, it's just a passive transmission of buildup of pressure, which leads to hemorrhage in the nearby area. Oh, I think you can rejoin with the same link if it gets disconnected. That's fine. So there are certain hemorrhagic lesions like thalamoventricular hemorrhage, striatohippocampal hemorrhage. So all these can occur with your nearby sinus thrombosis. So in our case, it's superior sagittal and your transverse, where we expected somewhere around parasagittal and temporal lobe hemorrhage, which is not present in our case actually. So this workup, I just want to clarify certain things alone. We have to do, especially in the background of a previous baby affected, we are planning to do that actually. But during the acute episodes, the levels of homocysteine and protein C, protein S, and lipoprotein A levels are decreased because of the consumption of these factors in that thrombus itself actually. So it is not reliable and you have to take it to the pinch of salt actually. And heparin therapy can affect some of the factors and warfarin therapy can affect some of the factors. So we have to look at all these thrombophilia workup actually. We are planning to do that when the baby recovers actually, after we stop our heparin therapy. Just now we stopped and we are planning to do that actually. Another point with your heparin is that there is some logistic difficulties here actually, and the loading dose of heparin is very huge, unlike in a older child or adult. We have to give 75 to 100 units per kg loading and followed by a continuous infusion of 28 units per kg per hour. So that is because the half-life is very shorter and the efficacy is also low because of low antithrombin levels. The antithrombin levels will be the mechanism of action for that heparin. So they require higher doses. So don't hesitate to give higher doses. That's a taking point for that. Having said that, low molecular weight is far better. And we initially started with unfractionated heparin and later we arranged low molecular heparin. That is usually given. That is what the most of the bodies recommend also. You start your therapy with your unfractionated heparin and you change over to low molecular heparin. That is also a good strategy, not a bad one. Low molecular heparin, the most important advantage is that there is a decreased risk of heparin-induced thrombocytopenia, and other side effects are far less. And the only thing is that you have to do anti-10A monitoring, though the side effects are very low. Thrombolytic therapy with TPA, usually we don't consider for your cerebral venous sinus thrombosis. Usually it is whenever there is a significant organ damage, you can give, or limb damage, especially in a catheter-related thing, you can consider that. But usually in cerebral venous sinus thrombosis, we don't give. And there are some few reports where they have done an invasive thrombectomy and have got some success. And there is some recent meta-analysis showing the evidence of thrombolytic therapy with heparin. So the long-term outcome is not very much different, but definitely it improves the progression of, it avoids the progression of thrombus. So for that matter, actually it is generally advised for all cerebral venous thrombosis to prevent the progression, we have to start heparin at diagnosis. So when there are some logistics, you can even overlap with anticoagulants, so this is not the standard criteria. Only thing is that when you plan to start warfarin or oral anticoagulants, you should be very careful because you have to overlap with heparin with a relatively longer time because of the decreased activity of protein C, which increases the prothrombotic state during the first 24 to 48 hours. So you should be very careful while starting oral anticoagulants. I think this will be the things which I wanted to highlight actually. So in this case, the most important thing is that there are certain two different presentations. These two clinical phenotypes is very important to understand. So that is the basis of differentiation. So because of this traumatic delivery, direct molding, direct endothelial damage, there is some problem with that actually. So those are the only things which we wanted to highlight. And another thing with the imaging is that nowadays people are going more into avoiding contrast. The diagnosis with your MR venogram with your gadolinium contrast is very easy. But the problem is that most of them are associated with hemorrhage. And when you give a gadolinium and that gets stagnant in the body, it can cause some amount of long-term problems. That is a concern. So people are trying to find or diagnose it without having a contrast. And without doing a contrast only, it creates a lot of problem basically. You have to be very well versed with that and has to have some amount of experience with that actually. Though we did contrast and that made our life easy, and you can easily see the flow void in sagittal sinus and transverse sinus, which drastically improved following your heparin therapy. We gave around for 6 weeks actually. The recommended one is 6 weeks to 12 weeks. So we are still under evaluation for the hypercoagulable state, and we will update that once we get the report actually. So during MRI without contrast, there are some things like we have to classify it as a hyperacute stage or acute stage or in the chronic stage, where the initially you can find it only in T2 and later you can give a hyperintense signal in T1 and T2. So there are some difficulties, and that is what is called as the time of flight sequence and TOF sequences instead of your contrast. So that is what people are trying to do right now. I think these are the only things that I wanted to highlight. There are some take-home points and some good learning points in these things. I think that is why we are presenting this case basically. Yeah, any doubts, I'll be glad to clarify them. I think Ramya madam joined late, I think, and Satya madam is also here. Any doubts, I'll be glad to clarify. And Mohit, regarding your presentation, I just wanted to have a reference for all. That's very important at your level. Try to put the reference wherever you take. Even if you give an incidence, it needs a reference. Actually, there are some quite good systematic reviews also. So those systematic reviews are very recent. Previously, all those are expert reviews, and off late only we have that systemic review. Off late, by which I mean around 2018 to 19. So during that time only we had some good reviews, actually systematic reviews, which clearly states that now this has become the standard of care. Actually, yeah, starting heparin. So there is no doubt about that. Actually, I have to quote all those things. Those are the only things that we are trying to learn from this case. So one is that late onset seizure. We did actually CSF analysis in this baby also. The baby had a local IV site phlebitis sepsis only, and no other systemic sepsis, and otherwise doing well baby. So we didn't find any cause for the seizure, and that fifth day seizure remains unexplained throughout the course, and we are a bit hesitant to stop your tone. So we did a HNNE, and once it is normal, we decided to stop it actually. So one of the strong possibility here is that the inherited thrombophilia, primarily because the previous child is also affected and has a similar presentation. This potential manifestation is very important because next time when you want to prevent it, this cesarean section can easily prevent that. Because the traumatic delivery with molding is the one thing which is very primary pathology for all those stasis. So try to avoid that. In the meantime, you try to avoid rule out inherited thrombophilic state. Any other doubts? I think the meeting is also going to end, and if no other doubts, I think any prothrombin done for this baby. Yeah, we are planning to, and because of the logistics only, all those are very costly, and because some of the factors are consumed during the acute thrombosis, we don't want to repeat it again because of logistics. We are just waiting to complete the heparin therapy, and after those effect of heparin weans off, we are planning to take the prothrombotic workup. As I said, we had to know about the factors which can be affected by heparin therapy. We're just waiting for that. Standard therapy is 6 to 12 weeks. We have documented a clearance of thrombosis in our case, basically. MRV is quite normal, actually. We had established a recanalization of thrombosis in our case. If it persists, actually, long-term progression of thrombosis is not there. The success of recanalization with heparin is somewhere around 50 to 70%. That's what many people have. And role of TPA is only during the acute stage, and that too in cerebral venous sinus thrombosis. Not right. It's about the early initiation of your heparin that is more important. Yeah, that's what I said. Here the bleed is not due to coagulopathy. Here the bleed is because of backflow because of thrombus. So that is not considered as a contraindication. You continue therapy with heparin. That is a pathophysiology you need to know to identify that. Yeah, 16,500 is very high for us.